Hello, and welcome to the Alabama Public Health Training Network. I'm Brandon Vaughn with the Alabama Department of Public Health. Thank you for joining us today for our program, Cervical Cytology and Pathology, Basics and Beyond. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear later again in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and nurse practitioners for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. CE credit awarded for this program will expire on November 30th, 2021. And now let's meet our presenters today. Krista Hood, Senior Nurse Practitioner in the Bureau of Family Health Services, and Stephanie Phillips, also a Senior Nurse Practitioner in the Bureau of Family Health Services. Later in the program, we will hear from Nasa Hernandez and Dewana Tatum. Welcome to each of you. And now to get started, Beth Allen, our Nurse Practitioner Director, would like to say a few words. Beth?
Thank you, Brandon. Good morning to all, and thank you for your attention to our program today. So why are we talking about follow-up again, you may ask? Well, this year we embarked on a quality assurance review and submitted that plan also as a part of our collaborative practice plan. So we have audited 100% of abnormal pap smears since January of this year. Since that time, we have found gaps in interpretation of pap smears and the understanding of that. And so this program will certainly take us and update us to another level where that's concerned. Krista will talk about today and outline the historical perspective of the Bethesda system and the use thereof. She will talk about a new risk-based management model. She will also give perspective as to colposcopy and that endeavor that we have embarked on. Stephanie will then jump into continuity of care in our follow-up process from the abnormal pap perspective. We've referenced a couple of articles that will be ongoing part of our training in model clinic through ACOG around referrals and tracking that Stephanie will cover. And then Nasa and Stephanie will extend that to our process, our applied application at ADPH for follow-up. Nasa will introduce our newest adventure of colposcopy and the follow-up process around that. And then at the end, Dewana will actually give visual images of our colposcopy patients that we have seen in our ADPH clinics. And then she will apply case study application to those cases and updates and the use of the ASCCP algorithms. So this subject is not new to us, but something that we are excited to present and to give updates of information. And we will continue this 100% audit forthgoing, and with this presentation make changes to the way we audit and to the way we follow this so that we can have the best care for our patients in the state of Alabama. So let's get started, because I know y'all are interested in hearing the presentations, and Krista's going to start us off this morning.
Okay, thanks, Beth. Good morning, everyone. I'm going to talk about, I'm going to go through the faculty slides. Okay, so my presentation today is on cervical cytology and pathology, the past, the present, and the future. So let's start with the quote. You can't really know where you are going until you know where you have been. So our objectives today are going to review the history of the Bethesda system. I'm going to provide an overview of the lower anogenital squamous terminology, discuss some evidence-based research studies that help guide and provide the framework for why we do what we do. I'm going to give a summary of some of the QA findings. We're going to examine the relationship between HPV and cervical dysplasia, and I'm going to discuss the new ASCCP risk-based management guidelines. So let's talk about Bethesda, or TBS. When I started the the research for this presentation, I thought a lot of people probably think Bethesda is someone's name or an acronym for something, but it's actually a location. It was in the first conference occurred in Bethesda, Maryland in December 1988. There was a group of cytologists, pathologists, clinicians, and they were all invested in determining how to provide standardized terminology and reporting of cervical cytology. The reason they wanted to standardize things was so that, for example, a patient was seen in Alaska and had a pap smear and now moves to Alabama. We want to be able to interpret that report. The provider should be able to read the report and use the same terminology. You know, the list of all the different terminologies also in our ADPH protocol in the follow-up chapter. And this Bethesda system is also used with thyroid cytopathology as well, so you might see that on some reports. So this is just a graphic that looks at the evolution of terminology and the nomenclature that's used for cervical dysplasia. Years ago, this graphic's from 1966. There was the use of classes, class 1, 2, there's SIN 1, 2, 3, there's mild, moderate, and severe dysplasia. So in an effort to standardize things so we're all on the same page, Bethesda is using that for our cytology. So this is an example of one of our cytology reports. As you can see, it starts off with the test which is your thin prep or your liquid-based pap smear, your interpretation, which this was ASCUS, your specimen adequacy, and any comments. So as far as the specimen adequacy, when you submit a pap smear, there's either the conventional or liquid-based pap smears. We use a thin prep liquid-based pap smear. There's HPV testing, we use hybrid capture 2, which requires 4 milliliters to be processed. So when you're looking at the satisfaction of the specimen and the presence of the transformation zone, the pap smears that we submit for adequate cellularity have to have 5,000 minimum absolute number of cells present. So that's 5,000 well-preserved squamous cells from the ectocervix. And typically a pap smear that we obtain will have about 12,000 to 28,000 squamous cells. So that sample could actually be reprocessed 3 or 4 times and still have an adequate result. The only problem sometimes we have is with postmenopausal patients. Due to atrophy, you may not have an adequate number of cells. And for the transformation zone to be present, you have to have 10 squamous metaplastic or glandular cells. And there used to be the presence or absence of the transformation zone. We used to interpret that differently, but currently there's no bearing on our follow-up if the transformation zone is present or absent. And another little interesting information was that with HPV testing, for the HPV test to be positive, there has to be a certain viral load threshold met. So with HPV testing, you might actually still have a subclinical or non-productive infection. It could be like a smoldering infection. So you don't want to ever say the virus is cleared, or when the patient's asked, do I still have it, or do I clear the virus? You don't want to say you've gotten rid of the infection. You may still have the infection. You still have the infection present. It just may not be replicating. So I think that's important to know that it just might not be detectable. So you may be positive 1 year. You know, there might be times where it's negative because it wasn't detected, because it didn't meet that threshold. This slide just talks, sorry, let me go back. This slide just talks about the format for general categories. There's the negative category, or NIL. I often document when I look at a pap smear. If I read the pap smear, I'll document 2019 NIL or NILM. And if a patient tells me her pap smear was negative in, say, 2017, I just write normal because I didn't actually visualize that report. There can be squamous and glandular cell abnormalities, endometrial cells present. There's the ASCUS terminology is used there, or ASC-H. What's really important about that is that you read the report in its entirety, that you read to make sure that you're not misinterpreting a ASC-H for an ASCUS. So you have to read the entire report so that you don't misinterpret that and not send the patient for further follow-up like a colposcopy. There's also low-grade and high-grade listed on the reports in squamous cell carcinoma and glandular cell abnormalities, like atypical endocervical cells, endometrial cells, glandular cells. And what is also important about this is when you see atypical, say, glandular cells, or the glandular abnormality should also include an endometrial biopsy with their workup. So not just a colposcopy, an endometrial biopsy is also indicated for most of those patients. And this is just another list. Like I said, this is in your follow-up chapter if you have any questions. If you ever get a report back and the terminology does not match what our protocol states and what we're telling you about Bethesda, then just let us know through a consult about that report if you have any questions. Okay. So let's go on to the LAS terminology. So LAS stands for Lower Anogenital Squamous Terminology. And this slide shows a lot of different terms that are used to describe a lot of things, but a lot of things are similar, and there's older terminology used with newer terminology, and it's just, there's a lot of, it gets complicated. So to describe things the same way, this is why Bethesda and LAST were implemented. And for example, we had a case study last year of a malignant melanoma, and one of the differentials was boinoid dysplasia. So that was just in 2018. The terminology was still being used that was older. So about the lower anogenital squamous terminology, it's a two-tier terminology for histopathologic samples or diagnosis. So it's the same principle as Bethesda for cytology. So when you get your reports back, there should be two tiers, lower grade squamous intraepithelial lesions or high grade. So these terms should be used for all sites in the male and the female genital tract, lower genital tract. So we used to say SIN 1, SIN 2, SIN 3, vein, like vulvar or vaginal, intraepithelial neoplasia. Those were all graded, like SIN 1, 2, 3. And the problem is grade 2 lesions are poorly reproducible. They vary, so some can progress to high grade, some can progress to low grade, and SIN 2 is the threshold for colposcopy. So you will still see on our reports that they're mixing the terminology together, but the goal is to one day only use low grade or high grade to describe a histology or our pathology report. But on our pathology reports, they still say SIN 1, SIN 2, SIN 3 used. So this is just a graphic about, again, terminology and all the different ways that we've used to say the same thing. The last nomenclature is listed with low grade and high grade in the Bethesda system with your NEOM, your ASCUS, again, your low grade, your high grade, your carcinomas. Another thing before we move on from pap smears, the lab gave me a few pointers about cytology specimens and how it's best to collect those, and some things they see that may be helpful. That when we're sampling, that we want to be careful not to over-rotate the cyto brush because we can damage or cause trauma to that to the cervix and the cells. So it only takes about a fourth or a half a rotation, so you don't want to over-rotate the cyto brush. And when you obtain your sample, you want to immediately agitate that in the specimen. You don't want to just put the brushes in the preservative and then go on to your biomanual, do more education, counseling, whatever's going on. You want to immediately try to get those cells off the brushes through agitating it, trying to fling the cells off the bristles in the cyto brush, because they can clump together and make interpretation more difficult for the cytopathologist. So I just thought that was interesting. That was not something I think would help me to make sure my specimens are adequate. Okay, so let's talk about some evidence-based practice. So practice that relies on scientific evidence for guidance on decision making. So we're not just making decisions based on our intuition or something that's unproven. So we've already talked about Bethesda and LAST, so let's move on to some research studies and to give you kind of a framework or a background. So the ASCUS, or low-grade triage study for cervical cancer, often referred to as ALTS, was a clinical trial that was done to find the best way to help women and their doctors decide what to do with this mildly abnormal and very common pap smear result of ASCUS and low grade, because most low grade changes we know regress spontaneously, and only a minority of those lesions would progress to a cervical precancer or precursor without treatment. And prior treating these lesions would then, we know these lesions 90% of the time or more would regress. So there was no way to know if they were going to regress or not. So they tried to determine a way to triage patients. So every year there's about 3 million ASCUS or low-grade pap smear results. For this study, there was over 5,000 patients enrolled. It was funded by the National Cancer Institute. UAB was one of the 4 centers that was involved in this study. And the point was to compare what was the most efficient and cost-effective way to manage these results. The management strategies they looked at were, do we send patients for immediate colposcopy? Do we repeat the cytology and a colposcopy with a higher grade lesion, or do we co-test with a referral for colposcopy if the HPV is positive and the cytology is high grade? Okay, so the findings were the HPV is sensitive in detecting the underlying precancerous lesions in pap smears like the ASCUS result. So that helps us, that guides us for, let's say, for example, you have a 25-year-old and we order a pap smear and we reflex it and it's ASCUS, but the HPV is negative. That helps guide us for what to do, because we know that HPV testing is sensitive, and that gives us a chance to put her in like a surveillance and see her back in 3 years instead of seeing her for colposcopy. The HPV testing is not useful with a diagnosis of low-grade or LSIL. So, you know, our 25-year-old, again, we don't need an HPV test because it's not useful it's not going to change our management strategy based on what the HPV is positive or negative. And as we said earlier, a lot of things are, interpretations vary, so expert interpretations still vary amongst pap smears. Okay. So another research study I want to talk about is Kaiser Permanente in Northern California. This study, like I said, gives a framework or background for the management guidelines from ASCCP. So Kaiser was by far the longest and the largest, has the longest and largest real clinical experience with HPV testing and co-testing. It was a very large study group, and it provided a lot of data. Kaiser is a large managed care organization in 8 states. So Kaiser had 1.5 million women ages 25 through 65 years old. And you can see the information about how many cancers, how many SIN3s and SIN2s were detected. They looked at the data from co-testing and HPV genotyping, the effects of vaccination for HPV, and they also compared the CDC, the National Breast and Cervical Cancer Program data, so that we would have a cohort that was similar with low-income, underinsured, or uninsured patient population was included with that analysis. So, moving on to some of the QA findings. So, as Beth already told you about our 100% QA, I just want to go over a few things that I noticed, or that we noticed. So, with this algorithm, with the ASCUS HPV negative algorithm, like I said earlier, Kaiser, the analysis from that information provided the background to determine whether a patient would, in 5 years, what their likelihood or the percentage of patients that would progress to SIN3. So an ASCUS negative is a low risk for progression to SIN3, but it's still a higher risk than a negative co-test or a negative pap smear and HPV negative. So, for example, that 25-year-old that's ASCUS HPV negative, we're not going to send her for another co-test in 5 years. We're going to see her back in 3 years. And then if, again, 3 years later, she's ASCUS negative, that's when we still need to evaluate that, look at her history, consult for further guidance, because while the risk is low for SIN3, there is still a risk present, so she cannot go any further than that without further evaluation. So this is actually the data about that typical scenario. So the threshold for colposcopy is 4%. So the data from Kaiser helped us determine the calculations to provide this information for you. So we're going to discuss more about this when we talk about the ASCCP risk-based management guidelines a little bit later. But at the bottom of the graphic, it shows an ASCUS HPV negative. So it's a little pink line, and it says 3-year return. And it's a 0.26% risk that in the next 5 years, that patient will develop SIN3. So, like again, I said the risk threshold is 4%. So at 0.26%, that's why she doesn't go to colposcopy. And then for an ASCUS positive, that patient's risk in the next 3 years of, in the next 5 years of developing a SIN3 is 5.2%. So over 4%, go to colposcopy. So that's how the data is presented, and that's why we do what we do. So for post-colposcopy management, when you have a patient with an ASCUS HPV positive, for example, she goes to colposcopy, her results are SIN1 or less. Her follow-up, so let's follow the guide on the left side where it says follow-up treatment, co-test in a year. So co-testing in a year for this patient, post-colposcopy, 1 year post-colposcopy follow-up. Her results are, for example, HPV negative, cytology negative. 3 years later, we do age-appropriate retesting. So, for example, that patient 3 years later is 28 years old. She would not get a co-test. If she was over 30, she gets a co-test. If those results are anything other than negative, HPV negative, she goes back for colposcopy. I think that was one of the findings, was that you have to look at the whole history when interpreting what the next follow-up steps are. So, yes, that is 4 years later from that when that colposcopy occurred, but it still makes a difference with her risk that she could develop SIN3. So those patients that are anything other than normal go back to colposcopy. And if you ever have any questions about that, you can always reach out to us as we go through the new risk-based management algorithms. Things are going to change, but for right now, this is the algorithm that we follow for management. Okay, so moving on, let's talk a little bit about HPV and cancers. So with this graphic, you see that cervical cancer is just the tip of the iceberg. There are a lot of cancers, oropharyngeal cancers, anal, penile cancers. They're still related to the HPV virus. So I think that's just important to know that, you know, while these we're not seeing, we do still see cervical cancer, but there's such a rise in the oropharyngeal cancers because we do a great job with screening for cervical cancers. And unfortunately, right now there's not a lot of good screening tools yet for other cancers, so their numbers are rising. So I just think that's really interesting. It's something when we talk to patients about HPV vaccination that you need to take into account, not only if you're female, but males too, because the male rates of these type cancers are rising. So we do a really good job of discussing HPV vaccination and counseling our patients and educating them. However, we can do better. So I've had patients or friends tell me, well, I'm not worried about my child. I have boys, so I'm not worried about the HPV vaccine for them. We need to be concerned about the HPV virus in males. So just, continue to encourage and educate and counsel patients on the HPV vaccination. Okay, so high-risk HPV and cervical cancer. So high-risk HPV is necessary as the agent in the pathogenesis of cervical cancer. And 99.7% of cervical cancers worldwide, high-risk HPV is present. Like I already said, HPV positive detection is present in cancer and more cancers, or the oropharyngeal cancers, the larynx, the tonsillar cancers, base of the tongue, the oral cavity, and that's why vaccination is so important for males and females. So HPV infection, as I mentioned earlier when we were talking about testing and viral thresholds to be positive or negative, HPV can have 3 courses: sustained remission, where the immune response contains the infection; productive infection, where cofactors could also be present, and HPV is replicating. So things that we talk to patients about is smoking. Smoking cessation is very important, and it is very important when it comes to HPV infections and cervical cancer. And infections like chlamydia. oral contraceptives, progesterone effect on HPV expression has been studied, nutrition, immunosuppression, leading to more of a productive infection, or there's neoplastic transformation where there's a persistent infection. So again, like I said, you may, there's often such a, patients feel so upset when you're talking to them about their Pap smear results, and you're telling them that their Pap smear result was HPV positive and they're going to need colposcopy. And I feel like there's such a stigma about it still, that they feel that they don't understand that there's millions of cases, that HPV is very common, and that most people have contacted HPV. So I don't want patients to ever feel ashamed when they come in for counseling on their Pap smear or their colposcopy. Okay, so again, this is just a graphic about smoking cessation and the time it takes to clear HPV for a smoker and a non-smoker. So please encourage your patients to not smoke, so their HPV test can be more clearance of the virus. Okay, so keeping on talking about HPV, addressing the need for advanced HPV diagnostics, or the ATHENA study. This included 47,000 women. It's the first screening trial for the HPV genotyping for 16, 18, and 12 additional high-risk HPV types. It's FDA approved for primary screening, so you'll see that as one of the alternative screening options with HPV only every 5 years. So the screening options for women 30 to 65 is cytology every 3 years, which yields about 0.76 deaths per 1,000 women. You have the high risk only every 5 years, which is 2.9%, and co-testing every 5 years, which is 0.3. So there's still a lot of research that's needed to determine if HPV only as a primary screen is cost effective, if there's any difference between co-testing. Right now they're of similar rates, so there's going to be more research about that as we continue to go. So let's move on to some pathology reports and just some information about, a little information about colposcopy, and then we're going to get to the guidelines. So this is one of our pathology reports. This was an endocervical curettage, and again, it's really important to review your cytology report. It's just as important to review your pathology reports. So with this patient, she had an endocervical curettage. There were fragments of focal changes suggestive of moderate dysplasia or CN2. And at the bottom, you'll see an addendum where a P16 stain was completed to help support her diagnosis of moderate dysplasia. So I'm going to go into that a little bit more. So what is a P16 stain? P16 is a tumor suppressor gene, or the biomarker for transforming HPV infection. So if there are positive results of the block staining, that's indicative of high-grade disease. It can help improve the accuracy of interpretation and the prediction for high-grade disease, and clarify discrepancies between your cytology, your pathology, and help guide you for if you're going to treat or put this patient in surveillance or further follow-up. It's not used if you have a definite CN1 or CN3. So that's another pathology report finding that you might see. So this is just an example of a positive block stain where there was an uptake in the staining on that stain, and this is a negative. So let's get to our case example for that pathology report. She was 23, gravida 1, para 1, and this was her Pap smear history this year. She was ASCUS. Last year in 2018, low-grade HPV positive. This was by an outside provider. We do not co-test a patient at 22 years old. And in 2017, at age 21, she was low-grade. So her colposcopy findings for external genitalia were normal. There was no lesions. Her squamo-columnar junction was not fully visualized. Dewana is going to go into this more about colposcopy standards, but that's an important part to remember when you're reviewing your colposcopy notes and pathology reports. So her squamo-columnar junction was not fully visualized. The ectocervix was unremarkable. There was no vascular changes like mosaicism or punctation, so we just obtained an ECC. There was not a cervical biopsy additionally on the ectocervix. So this was her cervix. This was the image that we took with Eva. It's unremarkable. We could not visualize the squamous columnar junction. So again, Dewana's going to go into this a little bit more. This is just another copy of our pathology report. So with the 23-year-old who had suggestive changes of moderate dysplasia, or CN2, the concern is, do you send a patient for LEAP when there may be future pregnancies desired, or can you conservatively manage her and do a PAP and another colposcopy in 6 months? So the P16 stain supported the diagnosis for moderate dysplasia. So we could not visualize her squamous columnar junction, so surveillance wasn't an option in this case, because if we could have visualized better, or we could have visualized, then we might have been able to not refer her for treatment for a leak. So it's very important to look at your reports in their entirety so that you know what to watch for and what to be more concerned about, so you can make the best decision for treatment for your patient. So let's go back to the future. And again, 5-year risk of CN3 by age and PAP results. Just at the top with the high-grade results for 5 years after a patient has a high-grade result, if they're 25 to 29, their risk of CN3 is 28%. So that's over the 4% threshold for colposcopy. Those patients go to colposcopy. Your low-grade patients at 25 to 29, their risk is 5. So it's over 4%, they go to colposcopy. So there's all these, that's how it figures into the data analysis for our risk-based management. So this is our risk bar. So what is the patient's risk? So equal management of equal risk. So that ensures that it's more simplified, it's consistent, and there's hundreds of different combinations because of the way we're going to start utilizing our history, or factors that can change the outcome, or so that we can have equal management of equal risk for precancer and cancers. So when you're looking at that risk bar, the purple-blue area is your 4%, their immediate risk that goes to colposcopy. So when we're talking about the new management guidelines, so I was fortunate enough to attend the 2019 ASCCP annual meeting, and it's really amazing to see all these different people that have contributed to this research and these guidelines and the future of patient management for cervical cytology and pathology, and to witness how they come together, how they form guideline committees, how they look at the research studies, how they interpret things, and how they come up with how we need to take care of our patients the best way, and how to prevent CN3, how to screen them properly, how to manage them properly. So this is not all just something that just happens quickly. It takes years, and as you saw that graphic from 1966, a lot has changed, a lot is going to continue to change, and it's really amazing to see that these are real people that are working in the community, that are seeing patients, that are talking with Dr. Thomas about our patients with UAB and Dr. Huh and all these names that you hear or you see on of the studies that are published, that they're really working with the research and the evidence to guide us with how do we better treat patients and how do we provide the best care that we can. So the new guidelines will go into further about treatments or colposcopy or short-term surveillance for 1 or 3 years or 5-year screenings. So, you know, there's a lot of backing, there's a lot of research, there's a lot of groups, ASCCP, ACOG, NIH, that are help supporting this with all the new information with genotyping and staining and vaccination, and there's just a lot going on. So for the new guidelines, again, it's a calculation. It'll be computer-based, so there will be no more paper algorithms. So that part of that protocol will go away. There will be all app or computer-based, a new program that will help to help program through what the patient's risk is so that we can decide what to do. So it's going to take into account their HPV status, the cytology, the history, if HPV typing was used, vaccination status, age, prior negatives, etc. So there's no way to make an algorithm for all those things because there's hundreds of combinations. So it will be a app-based where you'll enter the information so that results for managing are more precise. And I believe they're going to be simpler. I hope they're going to be simpler, and I hope there will be fewer colposcopies, more surveillance. That was kind of some of the case studies leaned that way, but we'll see. And we're really excited just to be a part of this new evidence, and we're at the forefront. ADPH is of. We're going to hopefully release these as soon as we can. Whenever we don't have them yet, or the access to that will be in 2020. But it's just really exciting. So that is all of my presentation, and I will turn it over to Stephanie.
Thank you, Krista. Today I'm going to be talking about referral and tracking of patients, and I'm kind of doing my slides right here at the beginning a little out of order. And just to go back and reiterate what's already been said, in 2019 we have performed a 100% audit of the abnormal pap smears within the health department. A huge disconnect has been found between the pap smears and the follow-up and the plan of care that our patients are receiving. So to ensure that our patients receive the best care, we look to national organizations like ASCCP and ACOG for evidence-based guidelines and recommendations for follow-up and referral of patients. From a medical legal standpoint, it is our responsibility to make sure that our patients receive the best care in a timely manner with an appropriate plan of care recommended after their evaluation. When a patient's referred to an outside provider, we must receive the records, review the records. We've got to close the loop between seeing our patient, referring them out, and the plan of care that follows and what's told to the patient. When we refer a patient outside the health department, contrary a lot of times to our belief, this patient is still our patient and we were responsible for them. So then I'm going back to the objectives right here. So the objectives today for this presentation is discuss our responsibilities when referring patients for care outside the health department, discuss the responsibilities of the provider, and discuss the purpose of a tracking and reminder system. So first, let's look at what is a referral. A referral is a formal request for a consultation. When we refer a patient outside the health department, we're requesting an evaluation. This is not talking about the referral or the nurse-doctor consult that we use within the health department when we're managing our patients. So when should we refer? We look at our patients, or when a patient comes in for a visit, we review their history, we perform a complete head-to-toe exam, and we combine those things with screening tests that we perform within the health department. When we do these things and we go back and look at them, situations or problems are identified that require a referral. A referral is needed anytime that we identify a situation or a problem that falls outside the scope of practice or the resources available at the health department. When a patient, and a good example of this was prior to colposcopies being performed at the health department. Another example of when a referral is needed is when the patient's request is in conflict to what we recommend. An example of this would be a patient who's a hypertensive diabetic who comes in and requests a combined birth control method or combined contraceptive. We know that this is contraindicated by the USMEC, and this is not what's best for this patient. It puts them at increased risk for adverse outcomes with the use of this birth control method. So they can, this patient may elect to seek care elsewhere. Also, another reason is that the patient seeks a second opinion or to explore care outside the health department. The first two reasons are the two that we see the most within the health department. There's different types of referrals that can be used. There's a single visit referral. That's the one that we most commonly see inside the health department or within the health department, and that would be an example of that would be when you refer a patient out for colposcopy. Then there's a continuing collaborative care and a transfer of primary clinical responsibility. No matter the type of the referral, our patient's care should remain our top priority and we should make sure that it's carried out in a timely manner. So let's look the different types of referrals. The first one we're going to look at is a single visit referral. And I mentioned earlier that this is like when we refer a patient for a colposcopy. Our responsibilities is to make sure that we provide all of the information needed for this provider outside the health department to make a recommendation back to us. If you look at the two examples on the slide, the top one, they're both requests for referral or requests for colposcopy appointments. On the first one, the request was returned and it said that a colposcopy was not needed. But if you look at the bottom one, there was an important piece of the patient's information that was left off of the referral or off of the request, and that was a leap in 2017. This request was returned with an appointment made for the colposcopy appointment. So we have to be sure and include the complete history when we're requesting a consultation or a referral. What is the purpose of documentation? Documentation tells the story of the patient. Someone will come behind us, whether it's a coworker, an outside provider, or a lawyer. Most lawsuits originate 12 to 18 months after a patient is seen. And our documentation is all that we have to go back to when we're reviewing this patient's chart. So strong documentation is always needed. The second type of referral that we're going to talk about is continuing collaborative care. An example of this would be a lot of our patients are under the care of a primary care provider for hypertension or diabetes, but they come to us for contraception. The primary care provider is responsible for managing the hypertension and the diabetes. Our responsibility is to make sure that we provide the safest, most effective contraceptive for this patient. So the responsibility for this patient lies with us and with that primary care provider. Another example of this type of referral is if we perform a breast exam and we find a breast mass. This patient is referred for breast imaging and a surgical evaluation. It's our responsibility to coordinate the patient's care and to make sure that they're aware of the plan of care and the plan of care is appropriate for the patient. There again, when we refer this patient to the surgeon, they are still our patient, and it is our responsibility to make sure that they're getting the care that they need. After this breast mass is evaluated by the surgeon and the imaging is completed and returns to us, if this breast mass is determined to be breast cancer, this would be the third type of referral, or a transfer of primary clinical responsibility. The management and treatment of this patient falls outside the scope of care and the resources available within the health department. So once the patient has been evaluated by the surgeon, the oncology team, and they're established with this care team, the care of this patient is turned over to that team, and the patient is closed to further follow-up at the health department. So now we're going to look at some case studies, and these are actual patients that we have found and seen at the health department. In this case study, you have a 22-year-old gravida 0 with a high-grade PAP that was referred for colposcopy. The colposcopy was performed and the biopsies returned were moderate dysplasia. The outside provider recommends the plan of care to repeat the PAP in 12 months. What should the nurse practitioner do in this situation? Agree with the plan of care or consult. In this situation, a consult is indicated because this plan of care does not follow the best practice based on evidence-based guidelines. And the management of a 21 to 24-year-old with a high-grade dysplasia is not included in the clinic protocol manual, so a consult is needed to assist in the management of this patient. Let me go back just a second. If we're unaware of this plan of care, if we don't review the records after this patient goes to colposcopy, or we agree with this plan of care, and in 12 months when this patient returns to the health department and they've developed cervical cancer, the liability lies with the health department. In this case, you see a 32-year-old gravida 3, para 3, who had an ASCUS HPV positive PAP. They were referred for colposcopy. The outside provider does not perform the colposcopy and returns the records back to the health department and says colposcopy not indicated due to minimal changes on the PAP. Repeat the co-test or the PAP in 1 year. What should the nurse practitioner do in this situation? In this situation, we need to refer our patient elsewhere for the colposcopy. We know, based on the evidence-based guidelines and ASCCP recommendations, that a colposcopy is indicated for the evaluation of an ASCUS HPV positive PAP in a 32-year-old patient. We must always serve as an advocate for our patients to make sure that they receive the recommended care. In this case, there was a 35-year-old gravida 3, para 3 with a high-grade PAP who was referred for colposcopy. On colposcopy, the squamo-columnar junction was not fully visualized, so an ECC was performed, and it returned with SIN3. The outside provider plans to do cryotherapy. What should the nurse practitioner do in this situation? Agree with the plan or consult. In this situation, a consult is indicated. Cryotherapy is not the best practice in this situation. The squamo-columnar junction was not fully visualized, and the ECC had high-grade dysplasia. If cryotherapy is used in this situation, it's only going to bury the disease and not remove the diseased area of the cervix. The use of cryotherapy in this situation is not okay. We have to be aware of the recommended follow-up and treatment based on the cervical abnormalities that are found, and in this situation, an excisional procedure instead of an ablative treatment is needed. So the patient actually needs a LEEP or a cold knife cone. Anytime the plan of care is not in agreement with the guidelines that we follow, a consult is needed. It's our responsibility to make sure our patients receive the best care, and we're doing them a disservice when they receive care that's not what we would expect. So if you have a patient that you refer to a provider and the care comes back, or the plan of care comes back to you, and it's not something that you're okay with for yourself, it's not okay for our patients. No matter the type of the referral, there are a few things to remember. There are a few things that are our responsibility, whatever the referral type. The patient is still our patient. We have to close the loop. We have to get the records. We have to review the records. We have to make sure that the patient is receiving the best plan of care for a future follow-up. If we disagree with the plan of care after the referral, we need to consult if it's needed or change the plan of care. We must always act as an advocate for our patients. Once a patient's referred outside the health department, a tracking or reminder system or a Tickler is needed. And what's the purpose of a Tickler or tracking of patients? It works as a safety mechanism to help keep our patients from falling through the cracks. We should not rely solely on the patient to complete the follow-up that we recommend, and there is a dual responsibility between the patient and us to make sure that they complete their care. Failure to follow up when the patient fails to follow up, it can result in adverse patient outcomes or liability to the provider because of delayed treatment or misdiagnosis. Failure to follow up on an abnormal result has been identified as one of the leading causes of lawsuits in clinic settings. Courts have held that the providers are responsible for notifying the patients of labs, imaging, and referral results. Tracking of patients begins at the patient visit. We need to educate our patients. We need to talk to them about what follow-up may be needed. Any information that we provide to them needs to be clearly documented in a chart. Tell them the reason for the referral, the differential diagnosis, what could be going on, and the adverse outcomes that could result if they fail to follow up. And then signed referral serves as documentation of the information that we've provided to the patients. No news is not always good news. When a patient comes to the health department and we perform tests, pap smears, lab results, they should be told when to expect their lab results and that we will contact them if there's any abnormal results. And if you haven't heard from us, to contact us in 2 weeks. We can't rely solely on the patient to get the information that's needed. If we go to the doctor for lab results, we expect to hear something in 7 to 10 days. Our patients should expect the same thing from us, and NASA will go into this in a little more detail later. Once a need for follow-up is determined, a Tickler card is needed. You can also create a task in the Cure, which serves as an electronic reminder, but it does not take the place of the actual Tickler card. A progress note should be started, and this is where we document any follow-up steps. All the follow-up steps must be documented on the progress notes and the Tickler card. Documentation should be prompt, accurate, and complete. An alert or flag needs to be placed in the banner in Cure so that anyone who enters that patient's electronic record is aware that this patient is in some type of follow-up. Many of our patients visit different health departments, and this is just helps ensure that when they go from one health department to the other one, everyone is aware of what's going on and that this patient is in follow-up. And it just helps keep our patients from being lost to follow-up. Review of the Tickler system depends on what follow-up steps are needed. If they need a phone call, if they need a letter, if they need a certified letter. So you need to review them based on where you're at in the follow-up of that specific patient's. And the Tickler cards and the progress notes should document any action taken or discussion held with the patients. Standardization of the follow-up process helps to eliminate errors or confusions when determining what actions is needed. All of us should follow the same protocol. The follow-up chapter in the clinic protocol manual outlines how to contact a patient, if it's a phone call, first-class letter, certified letter, how to document the follow-up, and the time frame for the follow-up steps that are needed. Tickler cards should document when follow-up appointments are scheduled, reminders about follow-up needed, dates or request of records, and then when they're forwarded to the provider for review. Tickler boxes should be kept in a locked, secured area, accessible to all steps, and they should not be the responsibility of one person. If a patient comes in and the follow-up nurse is not present, anyone should be able to access or look at those Ticklers and find out where this patient is in the follow-up process. Here's a list of trackable information. It's not all inclusive. Really, anything is trackable. Any test or lab that we perform, if a patient's referred outside the health department, we must make sure that we receive all of our records so everything is trackable. Would you want a test done on you and know when to follow up on it? Our patients deserve the same thing. When abnormal results are received, additional follow-up steps are required, and they're outlined in the clinic protocol manual in the follow-up chapter. Notification of the patient should begin within 5 to 7 days with a phone call or a first-class letter. If there's no response within 2 weeks, then a second notification letter should be sent in certified mail. Notification of the patient and scheduling of any diagnostic or therapeutic treatment should not be delayed waiting for the nurse practitioner to make the recommendation. Any notification or counseling of the patient needs to be documented, and an example of that would be spoke with the patient via phone about their pap smear HPV that was collected on 10/12/18 that returned ASCUS HPV positive, and the need for a colposcopy. Counseled patient on the worsening of the risk or the worsening of the disease to include cervical cancer or death, and the patient verbalized understanding. So it needs to include all of these things when you document that you've talked to the patient. Here are just some examples, or here are some times that a two-step letter process with a first-class letter followed by a certified letter are needed. Anytime we're trying to notify a patient of an abnormal result, we've got to make sure that they know what's going on. If a patient's been notified of the abnormal result and informed of diagnostic or therapeutic procedures, and they've been scheduled and they missed the appointment, you need to follow up with the two-step letter process. If the patient elects to schedule their own appointment for follow-up, we need to follow back up with these patients, and it requires up to a two-step letter process. Any patient needing repeat labs or PAPs, whether it's a 12-month follow-up for an ASCUS PAP in a 21-year-old or a 12-month follow-up post-colposcopy or LEAP. As mentioned earlier, follow-up is a dual responsibility of us and the patient. If attempts to follow up through the two-step letter process are unsuccessful, the chart should be flagged with a note in the banner, and the patient is inactive at that point, and the chart's flagged in case they return to the health department. If the patient has been scheduled for follow-up, whether it's a repeat PAP or colposcopy, and the appointment is missed, attempt to contact the patient and reschedule them. If they no-show for 2 scheduled appointments, it's considered a refusal of workup, and the chart can be flagged with a follow-up or with a note. The chart can be flagged with a note in the banner. And this is on page 3 of the clinic protocol manual in the follow-up chapter. After a chart is flagged, if the patient returns to the health department, we need to counsel them and document this on the Tickler card, on the progress note, anytime they come in and what counseling took place. If the patient elects to complete the workup at this point, the appropriate appointments need to be scheduled. After a patient completes the recommended follow-up, all records should be requested and reviewed by the nurse and the nurse practitioner. After the nurse practitioner reviews the records, a notation should be made in the progress note that the records were reviewed with the recommended follow-up and the plan of care. All records should be scanned to that progress note and not just included in the documents. They need to be attached to the referral that is used. The patient will then be notified of the plan of care, and the patient is to remain in follow-up until they return to routine screening. And don't ever just refer to the records, see attached records. Summarize the records, especially when we're doing consults with the physicians. Here's some situations where a consult is needed. If the follow-up is not completed as recommended, the patient, you may need a consult. Anytime there's a question in how to manage a patient, a consult is indicated. If we refer a patient to an outside provider and the recommended testing or treatment is not performed or follow-up is not aligned with the latest evidence-based guidelines, a consult is needed. If there's a discrepancy between the PAP and the colposcopy, for example, if there's a high-grade PAP and the colposcopy returns negative or SIN 1, a consult is needed. And if the patient goes for a LEAP and there's positive margins with high-grade dysplasia at the margins, and the recommended follow-up is colposcopy or an ECC and a PAP at 4 to 6 months, and the physician elects to just perform a PAP at 6 months, then a consult is needed. And in conclusion, sorry, those slides were longer and they were more than what I had. In conclusion, this just goes over collaborative practice. When a consult is needed and we don't complete it, we're not adhering to the guidelines set forth in our collaborative practice agreement. When we enter into collaborative practice in the state of Alabama, we agree to a formal relationship between us and the physician. This formal relationship allows us to practice under a physician in an advanced practice role. We're the physician's extenders in this situation. The guidelines set forth in the clinic protocol manual are evidence-based best practice, and as physicians extenders, we should adhere to these best practice guidelines. And thank you.
Excuse me. Thank you. At this time, we're going to take a break, and then we'll be back with the second part of our program. Welcome back to our program, Cervical Cytology and Pathology, Basics and Beyond. Our next presenters are Nasa Hernandez and Dewana Tatum, Senior Nurse Practitioners in the Bureau of Family Health Services. Welcome, Nasa and Dewana. If you would, please continue with your parts of the presentation.
Thank you, Brandon. Good morning, and thank you for joining us today. The objective of my presentation is to explain the detailed, standardized process for abnormal Pap and post-colposcopy follow-up. Now, what is the purpose of follow-up? Why is it important? And why do we keep talking about follow-up? So the follow-up process is in place so we can outline the steps necessary to provide the highest quality care for our patients, which is researched, evidence-based information, to ensure that the recommended therapeutic plan of care is carried out and to confirm the completion of the process. In order for us to do this, we need to have a full understanding on how the follow-up process works. And in doing so, we make sure that this is a standardized process where everybody is doing the same thing regardless of the clinic he or she works at. We need to make sure that all the results are received, that all the results are followed up, and all abnormal findings are followed up through to completion, because poor test results follow-up can have major consequences for the quality care of our patients, including misdiagnosis and suboptimal patient outcomes. So let's talk about abnormal Pap follow-up. This is something that we are already doing in the clinics, but we have noticed some gaps while doing our abnormal Pap audits. We all know that the first thing that happens is the nurse receives the abnormal Pap result. She will review and she will assign the results to the nurse practitioner for her to review and sign on these results and make a recommendation. You will not make any remarks on the lab forms. This is a medical legal document, and we also know that medicine is constantly evolving, so the recommended plan of care today may not be the recommended plan of care tomorrow. So you will not do any remarks on the lab forms. The nurse will have to open a referral or a progress note for this abnormal Pap. Then the nurse practitioner can make her recommendation in the referral form. This is the only place where you will document, and you will document every escalating attempt made to contact this patient and to counsel this patient. Let's talk about abnormal Pap follow-up. And like I said, you will have to open a progress note for every abnormal, regardless of the recommendation. If you have a 21 years old that has an ASCUS Pap, the recommendation is to repeat in a year. You open a referral form, you make a recommendation, you counsel the patient, and you document. If it's a 25 years old with an ASCUS negative and needs a repeat in 3 years, you do exactly the same thing. You open a referral, counsel, and document. It's been noticed that when doing the QA audits, a lot of people are just flagging the chart with this information. A referral was never opened. And what happens is, number one, this is not enough to flag the chart. We should not take any shortcuts when it comes to this, okay? And a lot of times they do flag the chart with the recommendation of repeat Pap in July of 2020. And this patient, even though the chart was flagged, this patient was never counseled, even though the patient had been in the clinic multiple times for family planning revisits, okay? Now, my question to you is, why would you not want to notify these patients of the abnormal results? Put yourself in their place. Would you want to be notified if you have a lab work done? I do. So we really should be informing these patients of all the results. In reality, any negative or abnormal results, patients should know this. But we do not notify if they have negative results at the moment. But whenever the EHR portal goes live, the patients will have access to all the results. So they will be aware of the negative results at that time. And we have talked about this a little bit before when Stephanie was speaking. We need to bring the process to an end. It is important that we close the loop. Either we bring the patient back to routine screening or we lose the patient to follow up. But either way, you have to document and you have to make sure that you close this patient to follow up. Now, let's talk about colposcopies and post-colposcopy follow-up when the patient goes to an outside provider. The same process at the beginning. You receive an abnormal pap, you review, you make a recommendation, and you send this patient out for colposcopy. You will make an appointment for the patient to go to the outside provider. Then what happens next? This is not the end. And we also noticed in some cases where the patient was referred out for colposcopy, and that was the last entry noted on the referral form. So it does not stop here. We need to make sure that we receive the results, we receive the plan of care from this outside provider. And Stephanie talked about this as well. You make sure you read this report from top to bottom. You need to make sure that the path report is included here. And then, once the nurse reviews these records, she will attach to the referral form, and she will assign this to the nurse practitioner. Nurse practitioners, you need to read the notes. You need to make sure that this is the appropriate recommended plan of care for this patient. And if it's not, if you notice that there is any discrepancies, you need to make sure you do consult. If you send the patient out for a high-grade PAP and the results of the colposcopy comes back as either benign or low-grade, this does not correlate to the high-grade PAP that you refer this patient out for. So you need to consult. And make sure that you document all this information. If you are in agreement with the doctor's recommendation, document so. If you're not and you consult with a collaborating physician, you're going to document as well. You make sure you document. And it can be a simple entry such as colposcopy results received and reviewed, patient contacted, counseled on plan of care and recommendation, questions answered, and the plan of care to repeat in 1 year. So it doesn't have to be anything extensive, just simple, straight to the point, but that you cover all the bases. Now again, just to echo what Stephanie just mentioned, don't forget, nurse practitioners, this is your patient. You collected the PAP. You send this patient to an outside provider because you could not perform a procedure. But if something ever happens to this patient, doctor is going to tell you, you send this patient to me. This is your patient, not mine. So it is important that you follow all the way through completion. If you don't remember anything else I said to you today, which I hope you do, but if you don't, just remember this. This is your patient. You need to take care of this patient. And we will continue to do this abnormal PAP quality assurance, and hopefully by the second quarter, everything will be in place. We will see some improvements on how this process is carried out, and everybody should be doing things exactly the same way. Let's talk about colposcopies done at the health department. We know that since the beginning of the year, specifically in January, we have been through different health department clinics performing colposcopies. We have been to Dallas, Montgomery, Shelby, Coleman, Bibb, and Butler County. Up till today, with our last clinic being this past Tuesday in Shelby County, we have done 265 colposcopies. Out of those 265, 41 patients had high-grade colposcopy results and were referred out for LIP procedure. This is about 15.4% of the patients that we have seen. And one of the patients was diagnosed with invasive cell carcinoma. So what we're doing matters. We really are making a difference. So what happens after we do the colposcopy at the health department? We will within a couple of days, we will upload the EVA system notes and pictures into the EHR. Then we, and when I say we, I mean the nurse practitioner seniors, we will wait for the results of this colposcopy. Once we receive the results, we will review the results, discuss with Dr. Thomas on recommendations, and we will append the original colposcopy note with the plan of care, recommendation, and so on. This note will be assigned to the follow-up nurse of the county the patient is from. If a patient from Walker County goes to Coleman County to have a colposcopy done, this note will be assigned to the follow-up nurse in Walker County. And this nurse will be responsible to notify the patient on these results and counsel the patient. Once the nurse do this, she will append the note again with the recommendation and plan of care, and she will assign this note to Dr. Thomas so we can close the loop, okay? So you can, the note will be a standard note, and this note is already in the current November protocol revision, page 2 of the colposcopy chapter. But you can document something just like this: colposcopy findings received with the plan of care, colposcopy findings were relayed to the patient, patient questions were answered, and plan of care was discussed. See the referral section of the EHR for details, and make sure you document the patient's individual plan of care, just as a co-test in a year, a LEAP, or a repeat colposcopy. And the LEAP appointment, if you need to send this patient out for a LEAP, make sure you do get this appointment before you append the note. That appointment date has to be included in your notes. Now, why are we bringing this to the forefront? Cervical cancer is highly curable when it's caught and treated early. Overall, I think we have done a great job screening patients with doing pap smears. Some patients will still get cervical cancer, mainly because they haven't had a pap in the last 5 to 10 years. First, we need to continue to encourage HPV vaccination, like Krista said, and we need to actively instruct our patients on the colposcopy services that we provide. Alabama has the 3rd highest overall mortality rate for cervical cancer, and we have been consistently in the top 5 for mortality rate in the U.S. Another startling statistic is that Alabama has the 4th highest overall incidence rate for cervical cancer. We are consistently on the top 5 for incidence rate in the United States. What we do matter, and that's why we do what we do. That's why we are embracing these colposcopy clinics, because we are making a difference. You guys are making a difference, and I thank you for all your efforts and for all that you do. Alone, we can do so little, but together, we can do so much. So I wish you all a happy and blessed Thanksgiving. Thank you for all you do. And I'll leave you with Tawana.
Good morning, everybody. Oh, I went backwards. So this morning I'm going to be finishing up talking a brief overview about the colposcopy procedure. We'll look at some colposcopy images, and then we'll finish with some case studies. So remember, these are all our patients. These are patients that you refer to Dr. Thomas for evaluation of some abnormal finding. So before we begin the colposcopy procedure, we actually begin with a thorough inspection of the perianal area. So we're actually inspecting from the top to the bottom, looking for any, changes, any hypopigmentation, hyperpigmentation, any moles, melanoma, condyloma. So anything that's not supposed to be there, you want to make sure that you identify that. Okay, so the next thing, there's several things that the examiner really wants to get a good look at, and the cervix is one of the first ones. You want to be able to visualize the cervix fully, and that's really important because that's basically what the colposcopy is for, to do a magnification of the cervix and the vagina. The second thing you want to look for is the squamocolumnar junction. Visibility. So is it fully visible or not fully visible? And I think we talked about this a little bit earlier, but the reason this is so important is because, like Krista said, the entities are trying to establish a standardized verbiage. You've probably heard people say the colposcopy was inadequate or unsatisfactory, or adequate or satisfactory. And imagine being that patient there, and you've just went through this procedure, you've had the ECC, the biopsy, and you hear somebody say, it's not satisfactory, and you're like, what are they talking about? So they're trying to go with something a little bit more patient-friendly. So the squamocolumnar junction, visibility, fully or not fully, is taking the place of adequate or inadequate. Then you're looking for any acetowhite changes, and that's any changes of whitening after the application of acetic acid. And acetic acid is just your household vinegar type solution. And once you put that on, what this does is it cleans the cervix, and it also allows any precancerous cells to turn to different degrees of whitening. So the degrees of whitening is what you're looking for low-grade disease versus high-grade disease. Also, you may hear some colposcopists use Lugol solution, which is an iodine-based solution, and that also highlights any abnormal changes. So there's some distinct characteristics of which are unique to high-grade disease, which are unique to low-grade disease, and they're all listed on this slide together. With the low-grade disease, you'll see that the color may be white, snowy white. The vascular changes are usually fine vascular changes. The margins are diffuse or geographic, so they're not well defined, and the lesion appears flat to the cervix. The high-grade disease usually is a denser, duller white. The vascular changes are more coarse. The margins are more straight or more demarcated, so you can actually see the exact margins. And the lesion appears pasted on the cervix or peeling off the cervix sometimes. So you could have a mixture of both. You could have the low-grade disease, you could have a high-grade lesion, or you could have a mixture of both in different areas. Also, the worst thing you don't want to see is the cancer, and we have actually had nurse practitioners out in the county health departments actually identify cancers just with a speculum exam. These are the patients. It's very important that they get referred today for appointments, and make sure if you ever have any questions or problems that you can consult our physicians. So once you determine that there's a lesion present, then you want to note the location and size. So in regard to location, you want to think of the cervix like a face of a clock, with 12 being the starting point, and then on around, as you can see. There are some normal findings that you may see, which Nabothian cyst, which is your mucus retention cyst, or you may see ectropion, which is the large squamocolumnar junction area, or you may see ectopy, and that's in your older menopausal, perimenopausal ladies. That would be considered normal findings. Some additional findings, you may see a endocervical polyp, and we have seen several of those, and that's usually just a benign growth from the endocervical canal. You may see that the cervix is friable. If the cervix bleeds easy, that could indicate disease as well as it could indicate infection. Satellite lesion, those are any lesions away from the squamocolumnar junction. You may note cervical stenosis, and that happens after cervical trauma or post-scarring, and that could happen either could happen after a cone or a leap. You might see that. This is, I think Chris has already alluded to all the different changes that is being used currently, high grade, CN1, adequate, inadequate. So this just kind of shows all the different terminology. So now let's start by looking at some of the colposcopic images. So on the left, this is before and after acetic acid. So on the left, you can see that there's some mucus, there's a little bit of a milky discharge, and so that could be obscuring some of the things under that. So after the acetic acid, you can see how it cleans it off very nicely, and you have to wait about 3 to 5 minutes before you start looking for your changes. So these are some thin acetyl white changes, and that's the acetyl white changes, remember, is where there could be tissue that is more apt to be abnormal or precancerous, and so that is the area that you want to biopsy. So you can see on this one that biopsy was done at the 5 and 8 o'clock area. Now this is an example of a dense acetyl white, so you can really see the difference in the previous one and this one. So the first photo on the left is really zoomed in, so you don't see the entire cervix. But the second thing you look for is the squamocolumnar junction, which is not fully visible. And then you're looking for your acetyl white changes, so you can see the whole anterior part of the cervix from 9 o'clock to 3 o'clock is affected. You can see that at the top left arrow, the borders are very distinct. And the bottom middle arrow, you can see where the actual lesion looks like it's peeling off the cervix a little bit. And then the far right arrow, you see just a couple of them, the both you cyst at the 3 o'clock area. Now on the right, it's not as zoomed in, and you probably can't tell as much about this picture, but I do want you to know that we do use the green light filter, and that helps to look for vascular changes in blood vessels. And this is just a low-grade disease side by side with a high-grade disease, so you can kind of see the differences. We talked about a satellite lesion. It's anything away from the squamocolumnar junction. So, you know, just because the ectocervix looks completely benign or normal, you want to make sure that you're looking behind the cervix or, you know, above the cervix. So you can see in this picture that there is multiple satellite lesions on the right anterior aspect of the cervix that look condylomatous. We do see a good bit of polyps, and they're usually able to be removed and sent off for evaluation through pathology. So this is a before and after picture, and this is more polyps. Now this is an interesting picture. This was a 42-year-old gravida 2, para 2. She came in with pelvic organ prolapse. And you know that happens when the muscles and tissue supporting the pelvic organs become weak, and it allows one or more organs to fall down into the vaginal area. So the first picture on the far left is just the speculum exam. The second, the picture in the middle, it's kind of hard to see what the anatomic picture is, but at the very top would be the urethra, and the patient, as she begins to bear down doing the Valsalva maneuver, you can see how it progresses to a little bit more of a prolapse. And pelvic organ prolapse is usually categorized from 0 to 4, with 0 being no prolapse and 4 being prolapse outside the vagina. So this lady was actually sent for surgical evaluation and treatment. This is a cervical cerclage, or also known as a vaginal cervical stitch. It's used to prevent late-term miscarriage or early preterm delivery. This particular patient came in, she had this cervical cerclage placed in 2007 that subsequently ended up in a C-section for unknown reasons, but she was complaining of some low abdominal pain, some discharge, and so when the nurse practitioner did the exam, this is what she found. So the nurse practitioner actually was able to take a picture and send it to the on-call physician, who recommended to refer this patient to Dr. Thomas. And so she did, and Dr. Thomas was able to remove this without any problems. So this is just to compare the two, the phone versus the EVA. Although the phone picture is not as clear as the EVA, you can see that it allowed for the on-call physician to be able to tell exactly what was going on and what needed to be done. So we'll start with the case studies. This is a 27-year-old gravida 0, LMP 11.5. She presents today due to ASCUS HPV positive. She doesn't have any complaints. She's not using any method of birth control, and she's not had unprotected sex. Her pregnancy test is negative, and that's very important to know before you see the patient for colposcopy, because there's certain things you would not want to do, like an endocervical curettage or an endometrial biopsy. You can still do the colposcopy, and you can take a look, but those are two things you would not want to do. Also, her STD testing was negative. So what is the initial management of ASCUS positive in this age group? So I think this was a really easy one, and I think we already all know the answer without even going through the results, and that is the colposcopy. This patient's going to be referred for colposcopy. So this is the algorithm. I think Krista showed it a little bit earlier of ASCUS, and your negative results would be on the left and your positive results would be on the right. So remember, this is a 27-year-old with ASCUS positive. This is after the acetic acid has been applied. You can see that there's a large ectropion, and that is where there's the the darker, beefier red is more of your columnar epithelium, and the outside, the lighter part that's smoother is more of your squamous epithelium, and this is larger in younger women. Postmenopausal women, you would not see this typically in them. So there was no acetyl-white changes, and an ECC was obtained. The colposcopy impression was benign, and the ECC was benign. So what is the recommended subsequent management for women with ASCUS negative in whom no lesion or CIN1 is preceded by lesser abnormalities? Now you're going to do age-appropriate screening in 1 year, co-testing in 1 year, or co-test in 3 years. And I think we have went over that as well, and that's going to be a co-test in 1 year. I just want to point out there are some symbols on this graph, and you want to make sure that anytime there's symbols, you look to see what the meaning of those symbols are. It actually tells you what the lesser abnormalities are. Also tells you what age-appropriate screening is. So anytime there's symbols, those are important. Follow-up recommendations in this 27-year-old with a history of ASCUS positive and a negative colposcopy is a co-test in 12 months. Your patient returns for her follow-up co-testing in 1 year. Her cytology and HPV tests are negative. She would like to know if she could have a positive HPV test again in the future. So what are you going to tell her? That she's now immune to HPV and will not have another positive HPV test in the future? We know that's not true. That she's completely cleared the virus and will not have another positive test unless she has a new exposure to the virus, and we know that's not true. She may have cleared the virus, or it may have become latent on the cervix. She could have a positive HPV test again in the future without a new exposure. And I think Krista already talked about you could have like a smoldering infection that is not going to be at threshold for the HPV test to be positive. So you could still have the infection. So actually that answer is correct. Or D, the HPV cannot be cleared, and she's always going to have that HPV. And so we know that's not correct. So the correct answer was C. So she's now 30, and her 3-year co-test is done. She has ASCUS negative, and the next steps are co-test in 3 years because it is ASCUS negative, or co-test in 1 year, or refer for colposcopy. The answer in this 30-year-old, because she is post-colposcopy, is going to be referred for colposcopy back. So you can see she is still under the management plan for the first 4 years. So anything abnormal in that time frame, she's going to go back to colposcopy. Oops. So moving on. So we have a 30-year-old seeking pregnancy for colposcopy due to a history of low-grade HPV positive. Her pregnancy test is negative. She smokes a pack of cigarettes a day for about 9 years. The external exam was unremarkable, and the cervix is fully visualized. So one thing we do to make sure that we are visualizing the cervix completely is you can use the spatula to put on one side to make sure that you're seeing, and then on the other side to also make sure that you're seeing the entire cervix. So I didn't want you to look at the EVA notes and think we were trying to do the pap smear in the wrong place. We're just making sure that we see the entire cervix. The second thing that we look for, remember, is the squamocolumnar junction. So it's kind of hard to identify here, so there are some things we can do. You can use a Q-tip to kind of manipulate the cervix to look for the squamocolumnar junction, because remember, that's going to predict if or dictate if the colposcopy is, according to the algorithm we have now, is adequate or inadequate, which we know that terminology will be changing. So you can see a Q-tip that's used on the left side and the endocervical speculum on the right. But even with the manipulation, this is the squamocolumnar junction is not visualized. But what we do see is a dense acetyl-white area at the 3 o'clock, or the 1 to 3 o'clock area. You can see the borders are very sharp, and on the bottom arrow pointing up, you can see that it almost looks like it's peeling up right there. So, the squamous-columnar junction was not fully visualized, and a biopsy came back SIN3. The ECC was benign. So, according to the ASCCP, what is the next steps for this 30-year-old with a SIN3 biopsy? Is she going to need repeat co-testing in 1 year, ablation, or diagnostic excisional procedure? So, we know the answer to that is she's going to be referred for a LEAP. And this is the management plan for the SIN2 to 3, which will be changing to the high-grade lesion terminology. And you just follow this down. Remember, look for the symbols because the symbols do mean a lot. The LEAP confirmed SIN3. The margins were free of high-grade dysplasia. So what is the next step? Co-test in 1 year, repeat cytology and colposcopy in 1 year, cytology and ECC in 4 to 6 months, or repeat the LEAP procedure. So the answer is because of the margins are clear of high-grade disease, she will need a co-test at 1 year, and if that is negative, she will need another co-test at 24 months. But again, you can see under the diagnostic excision procedure, there is a symbol, and that symbol tells us that if there is SIN2 or 3 at the margins of the LEAP or post-ECC, then cytology and ECC would be the preferred treatment in 4 to 6 months. So it's important that we look at all of our symbols. So this is the what if slide, and that is what if the margins were positive, and I think we just talked about that. The cervical cytology and ECC in 4 to 6 months. Option A would be the answer. So after the LEAP results were discussed, the patient and the follow-up was established. She wants to become pregnant soon, and she asked, is there anything that I can do to help decrease my risk of developing cervical cancer? So which of the following lifestyle changes would have the greatest impact in decreasing the patient's risk of developing cervical cancer? Would it be weight reduction, use of condoms with every encounter, smoking cessation, or alcohol intake? So the answer is actually smoking cessation, but weight reduction we know is important just for your overall health. The use of condoms with every sexual encounter is really not feasible because she's trying to get pregnant. And alcohol intake has not been really associated with HPV, so we know the answer is smoking cessation. That is an increased risk for HPV. And the more you smoke, the higher, if you smoke over 15 cigarettes a day, that really increases your risk even more. Okay, so next we will talk about a 21-year-old with an ASCH on her initial PAP. How should she be managed? Are we going to send her straight to LEAP for the see and treat approach? And we know that is definitely not recommended for this age group. I think Stephanie alluded to that earlier. Does this 21-year-old need an endometrial biopsy? No, that's not indicated either. Does she need the HPV test? Although the HPV test is probably positive, it's really not indicated for the 21 to 24-year-old. So this young lady is going to be referred to colposcopy. And this is just the algorithm, and you can see in this age group, the ASCH and high-grade algorithm is the same. So this was actually her colposcopy. So you can see the squamous-columnar junction was fully visualized with manipulation. There was some faint acetowhite epithelial noted from 11 to 1. There was no mosaicism or punctations, and so a biopsy was taken. So the results is that the colposcopy was adequate, which remember that means that the entire cervix and the entire squamous-columnar junction was visualized. The biopsy and the ECC were done. The biopsy was a SIN1 or low-grade lesion, and the ECC was negative. So what is the next step in this 21-year-old with a ASCH? So at this point, do you want to do a LEAP? No, we're still under conservative for this age group. An endometrial biopsy, again, is not recommended. A co-test in 1 year is not the correct answer, so you want to do the colposcopy and cytology at 6-month intervals for up to 2 years. And this is the algorithm that shows you the results. Remember the symbols. The colposcopy has to be adequate, the ECC has to be negative, so the symbols are very important on these algorithms. So what now? This was a 41-year-old that had no history of abnormal PAPs, although her last PAP was 5 years ago. She came in and her PAP results was AGC and high grade and positive HPV. She said her periods were normal and she had no complaints or no postcoital bleeding. So what is the next step? Do you do an endometrial biopsy only, colposcopy with ECC and endometrial biopsy, or HPV genotyping? So we know that AGC is managed the same for all women across the board, regardless of age. And this is one of the results that Dr. Thomas says should make your radar start going beep, 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 because AGC needs aggressive follow-up. So this, because she's over 35, she's going to be referred to colposcopy and with ECC and an endometrial biopsy. And she also had the high grade, so I put that in there as well, because you want to look at everything that is on the PAP, and it's still the same. I'm sorry. So this 41-year-old with AGC, this is her, an EMB was done. The squamocolumnar junction is fully visualized with manipulation. Biopsies were taken at 5, 7, and 12, and the colposcopist impression was a CN2. Now, just to speak just a little bit about an endometrial biopsy, probably a lot of y'all have seen that or know what that is, but it's something that we can do in the health department. You can see the endometrial tool is kind of a 2-in-1 tool. On the outside, you can see the numbers, so it's a sound. Basically, you're going to do everything like you're going to do to sound the uterus. You're going to make sure you know the position that the uterus is in, because you're going to be inserting this. You're going to sound the uterus, and once you do that, then you're going to pull the plunger back, which is going to create suction, and then you'll just remove the endometrial tool, twirling as you come out. Okay, so remember this was the 41-year-old AGC high-grade squamocolumnar junction fully visualized. Her ECC was a CN2. The P16 supported that diagnosis, and the endometrial biopsy was benign. So what is the next steps in treatment for this 41-year-old with an ECC of CN2? She needs to be referred for a LEAP. That is the answer, and you can see that here. Again, you want to look at these symbols. So this 41-year-old was referred for a LEAP, and she had a top hat done, which is a LEAP with actually a top hat is the separate, so you use 2 loops. The larger loop goes first, and then the smaller loop goes more into the endocervical canal. So you're actually getting 2 separate specimens, but unfortunately this young lady was diagnosed with invasive squamous cell carcinoma. She had tumors extending to the cauterized and ink margins. The recommendations were a radical hysterectomy and pelvic lymph node dissection. So the radical hysterectomy is where the whole uterus, the tissue on both sides of the uterus, the cervix, and the top portion of the vagina is removed. And she had completed this plan of care, and she will be following up with an oncologist. So like Stephanie spoke earlier, at this point the patient's care is transferred to the oncologist, because that is treatment that we don't do. We are not able to do that. So this really is a prime example of closing the loop. The nurse and the nurse practitioner made sure that the patient followed with the recommended plan of care, so that this helps for the patient to achieve the best outcome, and also decreases our liability to make sure that they are doing what they're supposed to do. And remember, this patient may come back to us in the future. She has 3 daughters and a sister, and she wants to know what could be done to prevent this from happening to them. So how should she be counseled? Do they need an annual co-test? Do they need screening colposcopy? Do they need the HPV vaccination or genetic testing? So we know the answer is HPV vaccination. I think Krista's already talked about it a little bit earlier. The importance of the HPV vaccination among all of our patients, male and female, to help prevent these types of cancers. Okay, something is wrong. So next we have a 28-year-old gravida 0 with the results of a low-grade HPV positive. The week before her colposcopy appointment, she calls to tell you she's having a discharge. So you tell her just to keep her appointment next week for the colposcopy, and they check her out at that time. So let me just stop right here and say, you know, not only is that good practice, if someone calls with a discharge or any kind of problem, or if they have a positive STD test, this has to be taken care of before the colposcopy procedure, so before the patient comes in. We want to make sure she gets treated because we will not be able to do the procedure if she has a problem. So this young lady had some non-painful sores to the labia and a moderate amount of mucopurulent discharge. So how do you want to proceed with the treatment of this patient? Do you want to go ahead and do the colposcopy? We know that's not true. B also has the same choice for the colposcopy. So we know the answer is C. You'll do the pelvic exam, you'll do the wet prep, you'll do the STD test, and you're going to treat for the MPC, but you're going to have to postpone the colposcopy procedure until another day. And sometimes that, you know, puts a hardship on patients. Sometimes we lose patients after that. It's hard to get people in, so we want to make sure that people are treated appropriately. So, in conclusion, it can be complicated. So any management plan outside of ADPH protocol or outside ASCCP guidelines, we need to utilize the expertise of our collaborating physicians and consult for guidance. And that brings me to the conclusion. Thank you.
Thank you all so much. I do see, Beth, that we do have a couple of questions via email.
Great. Thank you all for that great presentation, and I'm just going to jump into the questions. I want everybody to have an opportunity to send questions, call with questions, so lines are open right now, and then we'll have some closing remarks after questions. So the question is, patient had colposcopy, results SIN1, mild dysplasia, HPV, 12 months later, co-test negative, 3 years later, co-test negative, 3 years later, negative HPV positive. In this case, would we automatically refer for colposcopy or co-test in 12 months? You want to take that?
Sure.
Yeah.
So, first of all, let me just say thank you to the team, to the NP seniors and to Beth Allen. You guys did a fabulous job, and I'm appreciative of the effort as well that's put forth by you out there, our nurse practitioners and our nurses, and I thank each and every one of you for embracing our efforts with colposcopy, so thank you. So if I remember this consult correctly, this is somebody who is, I guess, remotely out from her.
We don't have an age there, but
Yeah, there's some information that's missing.
Yeah.
But anyway, and it doesn't say what the prior, what was the pap smear result that led to colposcopy, but the results show SIN1, and 12 months later she's had a negative co-test, and 3 years later a co-test that was negative, and then somewhere along the line she's got a negative positive 3 years later. And I think this speaks to the portion of the discussion where Krista talked about risk-based assessment and where we are in terms of future steps for pap smear management. So this patient will have to go back to colposcopy. Okay, this is the point where she would go for colposcopy. And what the risk-based assessment will tell us going forward is exactly where she falls on that line. And hopefully, you know, at that particular point, when we start using that risk-based assessment, the new tool, which hopefully will be in spring of next year, this patient, it will actually tell us the percentage of risk for this patient, and she may not need to go to colposcopy. So we probably will be performing less colposcopic exams, and this is better all around for our patients. So, but as of now, if you presented this case to me, she would be referred for colposcopy.
So we've got thank you, Dr. Thomas. We've got a couple of other questions. I just want to note that to get my bearings around the iPad, but all three of these questions are from Sarah Shelton in Marshall County. So thank you for your questions. But question number 2 is, if a patient is under PAP follow-up and states that she desires to continue PAP follow-up somewhere else and no longer wishes to come to the health department for care, can we document conversation with the patient and flag to follow up, or what is the process to flag this patient? So if she's our patient and we perform the pap smear, if I'm understanding this right, and she no longer wishes to receive care through us, then, you know, yes, you document that through your referral progress notes. I'm assuming that this is something that you say continuing PAP follow-up somewhere else. I'm assuming this is a referral scenario by the way the question is asked. So, yes, you would document that she no longer wishes to come to the health department for care. These scenarios are not one size fits all, and oftentimes you may also have to if the patient is choosing not to do follow-up appropriately, you may also need to talk to that patient and see if the patient wants to decline further services at all, and then she would actually sign a refusal for services that we have as a part of recommendations, and that would all go in the referral if this is a patient in abnormal follow-up. I think that answers your question on that. And then number 3 is, we have been receiving multiple PAPs from LabCorp that interpretation is negative, but under specimen adequacy it only states satisfactory for evaluation. It does not address presence or absence of ECCs. Is this a new thing with LabCorp or a problem that needs to be addressed with LabCorp? Should these be sent to the nurse practitioner for review? So if they don't have a statement about endocervical cell component, then yes, that would need to be brought to the attention of the nurse practitioner. And I don't know that that's, I'll let Dr. Thomas take this, but I don't know that that is new.
So the presence or absence of endocervical cells, does not have a bearing on whether PAP is, adequate or not. But if this is a pattern that is being noted, then it needs to be brought to the attention of LabCorp. So if those could be forwarded to me, and I can take it from there with LabCorp to bring that to their attention.
Thank you, Sarah, for your questions. I think we have a question. This one is from Latoria Bass, and she's got 2 questions, so thank you, Latoria. Question 1 is, if we contact the patient regarding the abnormal PAP and the PAP answers the phone, and the patient answers the phone, and the patient is counseled, do we still need to send a first-class letter or certified letter? So the phone call to the patient is a part of step 1 in the process, and that's perfectly fine. Just document that in the record and put that in your referral notes, just like I think both Stephanie and Nasa indicated. Any other comments to that? No? Okay. Question 2, if the patient does not keep their appointment for their colposcopy and we attempt to contact them via phone with no answer, do we send first class letter, then a certified letter, or 2 certified letters? So again, the follow-up chapter of the protocol outlines this, and the first attempt so that you can make the patient aware of their needs, is to send them a first-class letter. That letter is a little bit different in protocol than our certified letter. Our certified letter actually stamps out the fact, and we probably will make some tweaks to this as we continue with follow-up just a bit, but it actually outlines the fact that we have made multiple attempts to contact them. So when that certified letter goes, it says that, and that we're actually saying to them that they need to contact us if they want further care, is the way that we're going to go with that. But the first letter is sent regular mail, and the second letter is sent certified mail, and that's outlined in protocol. Okay. Thank you, Latoria, for your questions. I don't see any other questions via email. Do we have any callers?
I don't think we have any.
Okay, so I would just, like to say a couple of things and then give Dr. Thomas an opportunity to say. I, of course, would like to thank each nurse practitioner senior for your thorough presentations today, and we especially, as we were preparing for this, wanted to also thank our nurses and our clinic staff out in the counties, and of course our nurse practitioners. We want to thank the ones who have been involved in our Colpo process. We know that it's another something that you have to prepare for, and we know that it is more work. And the counties involved, Nasa mentioned, but I'll just mention again, are Coleman, Shelby, Bibb, Dallas, Montgomery, and Butler. And that way we have actually been able to touch each district statewide, and that was part of our goal. But our goal doesn't stop there. Our goal is for nurse practitioners to be able to do endometrial biopsies and to do colposcopy, and that is the vision that Dr. Thomas has that we're trying to carry out through this. And where we've seen the need being so great statistically, as NASA has pointed out, just gives us more push to get this up and going. So that's a hope that we will get this further along as we continue to progress with this in 2020. I obviously also want to thank our physicians, Dr. Thomas, Dr. Maxwell is here today, and Dr. Gillum for their support through our initiatives where we're trying to do more for the patients in Alabama. And we couldn't do this without their leadership, and I know you all know that. But our goal is the best care and utmost integrity in patient care for all our patients statewide. Dr. Thomas.
Thanks. Thank you, Beth. I think that, again, as public health providers, we're hard-pressed, I think, when we see that Alabama keeps coming in the top 5 across the nation for cervical cancer incidence and mortality. And actually, a Human Rights Watch group was in Alabama, specifically in the Black Belt region, and this sort of spawned a discussion around the overall poor health care that Alabamians receive, and women dying at alarming rates from cervical cancer. So patient care it's an arduous task. It's something that I think what this presentation emphasized today, that we are responsible for our patients, and that we have got to give them, or we try. I think we as public health servants have to lead by example, and that we have to provide the best care for our patients, and we have to be their advocates. And if we won't accept a certain treatment, or we will question our physicians, then we should expect the same and treat our patients in the same manner. Hold on to your seats. I think we're headed in a really good direction. I think with the new risk-based guidelines that are coming forth, I think for me it's fascinating to, after having been in practice as an obstetrician gynecologist for over 30 years, to see where we've come, from class 1 PAPs, I do remember that terminology being used, to now actually knowing the causative agent of cervical cancer and being able to treat these conditions, early and aggressively in some instances. Again, thank you for all the positive feedback. Thank you for embracing this again. There's nursing staff out in the county health departments that we could not do any of this without their help and diligence in corralling our patients. Those of us who've been in public health know that our patients are special. They're a special breed, and we've got to walk them through a lot of steps that you and I may take for granted, but that's part of being a public servant, I think. So, again, thank you for the efforts, and thank you for receiving colposcopy in such a warm fashion. And we're going to be doing LEAPs. It's coming, but these things take time in public health, as you well know. Thanks again.
Thank you, Beth. Thank you, Dr. Thomas. This concludes our program for today. I want to thank Krista, Stephanie, Nasa, and Dewana for being here, and thank you for watching. Please remember that you can refer back to the training and resources anytime on demand, and have a great day.